Hello, thank you for viewing this module on inclusive language in medical education. I'm Jaya Raj, Professor of Medicine and Assistant Dean of Diversity, Inclusion, and Belonging on the Creighton University School of Medicine, Phoenix campus. By the end of this module, participants should be able to articulate the importance of using inclusive language in the learning environment, explain key principles for using inclusive language and apply them in the educational setting, and recognize and use preferred over non-preferred terms when referring to people or populations. Using inclusive language is not just about being politically correct. It helps us achieve some very important goals. First, it helps to reduce stigmatization by eliminating terms that can perpetuate harmful stereotypes and biases. It promotes cultural competence by helping healthcare professionals understand and respect diverse backgrounds, beliefs, and perspectives. It can also enhance patient-provider and teacher-learner relationships by creating a welcoming environment that encourages open, honest communication and fosters trust. Inclusive language is also a necessary component of addressing health disparity, because inclusive language acknowledges and addresses the various social determinants of health which contribute to health disparities among different population groups. It also increases awareness and empathy by raising our awareness about people's unique experiences and challenges. The Centers for Disease Control is a valuable resource for anyone wishing to learn more about advancing health equity through inclusive language. On their website, they explain key principles for inclusive language, which we are going to review here in this module. The first key principle is to avoid the use of adjectives such as vulnerable, marginalized, and high risk. That is, avoid terms which imply that a condition is inherent to a group rather than to the actual factors which caused the condition. Instead, we should use language that focuses on the systems in place and explains why and or how some groups are more affected than others. For example, instead of referring to vulnerable or marginalized groups, underserved or underprivileged communities, or high-risk groups, we can instead refer to them as groups which have been economically and or socially marginalized, communities which are underserved, under-resourced, or have limited access to a specific service or resource, or groups that are placed at increased risk of a specific outcome. A second key principle is to use person-first language. In other words, to describe people as having a condition or circumstance, not being a condition. So instead of referring to patients as diabetics, the obese or morbidly obese, the homeless, the disabled, or the mentally ill, we can instead refer to them as people or persons with diabetes, obesity, or severe obesity. We can also refer to people as experiencing homelessness, people with mental illness, people who are incarcerated, or people experiencing a specific health outcome or life circumstance. Another key principle is to try to be as specific as you can about the population or group to whom you are referring. Instead of using broad terms such as minorities, minority groups, ethnic groups, racial groups, or disability groups, try instead to refer to people from a specific racial or specific ethnic group, people who identify with a specific sexual orientation, gender identity, or religious affiliation, or people who are living with a specific type of disability. Another key principle is to avoid language that unintentionally or unconsciously places blame on an individual. For example, we should not assume that people are refusing or choosing not to participate in a behavior or access a service, because access, acceptability, or other structural issues may play a role. So, for example, instead of referring to people who refuse vaccines or are vaccine hesitant, we can instead refer to them as people who have not been vaccinated. Similarly, instead of calling people non-compliant or saying that they do not seek medical care, we can refer to them as people without access or with limited access to health care. In addition to language, it is also important for us to consider whether or not the images that we are using in our presentations are inclusive. Inclusive images show diverse representation within your intended audience. They show appropriate use of cultural dress, activities, or objects and settings that are relevant to the intended audience and relevant to the topic you are discussing. They show positive portrayals, including positive health behaviors, as well as diverse beauty standards. We should avoid perpetuating stereotypical behaviors or power or status inequities. We should also avoid tokenism or creating a staged or artificial feeling. We are now going to go through the CDC's list of preferred and non-preferred terms in several common categories. These terms are preferred because they consider the context and the circumstances in which people live. We should remember that preferred terms change and evolve over time as we learn and evolve. So a preferred term today may not be what is preferred tomorrow, and it is important to continually update our knowledge. Preferred language respects the preferences of the people who belong to a group or identify with a group, and it acknowledges the existence of multiple subgroups and the diversity that exists within each group. The following is not an exhaustive list, but a representative list of examples. In the category of race and ethnicity, some non-preferred terms include referring to people as their race or ethnicity. For example, referring to Blacks, Hispanics, Latinos, whites, American Indians, etc. Instead, we should refer to them as persons, communities, or populations who are Black, Hispanic, Latino, white, American Indian, Alaskan Native, and so on. Terms such as Eskimo, Oriental, and Afro-American are also not preferred. Instead, we refer to Black persons, Native Hawaiian persons, white persons, or people who identify with more than one race or ethnicity. For sexual orientation and gender identity, non-preferred terms include homosexual, using MSM as shorthand for a person's self-identified sexual orientation, transgenders, transgendered, or transsexual, biologically or genetically male or female, or hermaphrodite. It is also not preferred to use gendered pronouns in place of gender-neutral pronouns when the preferred pronoun is not known or not specified. Preferred terms include lesbian, gay, or bisexual when referring to a person's self-identified sexual orientation. Queer, transgender, assigned or designated male or female at birth. Gender non-conforming, non-binary, genderqueer, or gender diverse. We should also use gender-neutral pronouns, such as the singular they, them, or their, when referring to people when the preferred pronoun is not known or not specified. There are also non-preferred and preferred terms referring to healthcare access and socioeconomic status. Instead of referring to underserved people or underserved communities, the uninsured, the homeless, transient, or the poor, we can refer to people who are underserved by a specific service or resource, people who are uninsured, experiencing homelessness, or experiencing unstable housing, people with lower incomes, people with incomes below the federal poverty level, or people who are experiencing poverty. Alcohol use disorder and substance use disorders are also associated with non-preferred and preferred terms. We do not want to refer to people as drug users, drug abusers, drug addicts, or alcoholics, or people who have relapsed. Instead, we should refer to them as persons or people who use drugs, people with a substance use disorder or alcohol use disorder, or people in recovery from substance use or alcohol use disorder. In reference to non-US born persons, we do not want to refer to them as illegals, illegal immigrants, foreigners, or illegal aliens. We can refer to them instead as people with undocumented status, people who are seeking asylum, people from refugee populations, or simply as non-US born persons. We're now going to go through a few case scenarios. I'm going to read each case scenario, and then I will read 2 questions that you are asked to answer with a very brief response. You may pause the module after I read the 3 scenarios and questions in order to enter your response in the quiz. First case scenario, Mrs. H, a 40-year-old Hispanic woman who is an uncontrolled diabetic, presents to clinic for a follow-up appointment. Although she has received education and counseling about diet, exercise, and weight loss, she is unable to lose weight and has a BMI of 34.5. She is non-compliant with her regimen of long-acting and short-acting insulin, but takes her metformin as prescribed. Question 1, what examples of biased language are present in this case scenario? And question 2, how could you change the language in this scenario to make it more inclusive? The second scenario, a 55-year-old Caucasian man presents to the emergency room with abdominal pain for 2 hours. The pain is diffuse, non-radiating, associated with nausea, vomiting, and diarrhea. The patient has been seen in the ER 3 times in the past 2 months for abdominal pain. Each time, his workup has been negative and he was sent home. The patient is homeless, uninsured, and has a history of alcohol and methamphetamine abuse, but he says he has not used methamphetamines in months. Question 1, what examples of biased language are present in this case scenario? Question 2, how could you change the language in this scenario to make it more inclusive? The third scenario, CK is a 26-year-old genderqueer patient who is biologically female. She is a new patient to your practice and presents today for cervical cancer screening. She reached menarche at age 13 and has regular periods which last 4 to 5 days with moderate flow. She is bisexual, uses oral contraceptives, and has never been pregnant or had a sexually transmitted infection. She is unvaccinated against human papillomavirus. Question 1, what examples of biased language are present in this case scenario? And question 2, how could you change the language in this scenario to make it more inclusive? You may now pause the video, click on the link or scan the QR code to access the quiz and answer a few questions with a very brief response. After completing the short quiz, you may resume the video. There are a number of terms which are biased that are present in this scenario. Terms such as uncontrolled diabetic and non-compliant fail to consider the context of the patient and unconsciously place blame on the patient. We can make the language in this scenario more inclusive by using person-first language. Instead of uncontrolled diabetic, we can refer to her as a person with diabetes that is not well controlled, or a person with diabetes whose blood glucose is not at goal. Instead of non-compliant, we can simply say that the patient does not take insulin. Scenario B, the 55-year-old man with abdominal pain in the emergency room. Examples of biased language include the unnecessary use of the word Caucasian or reference to the patient's race, which is irrelevant in this case. If race is relevant to the case, then the term white is preferred to Caucasian. The description of the patient's socioeconomic status, frequent ER utilization, and history of substance use disorder can all lead to bias. In order to make the language more inclusive, we can again use person-first language. Instead of homeless, we can say the patient is experiencing homelessness. Instead of uninsured, we can say patient is without insurance. And instead of alcohol or drug abuse, you can say he is a person with alcohol or substance use disorder. Scenario C. This is the 26-year-old patient who is presenting for cervical cancer screening. The examples of biased language in this scenario include terms like biologically female, which are non-specific and not inclusive. The term unvaccinated is an example of blaming language and does not take into account the patient's individual circumstances. To make the language in this scenario more inclusive, we should use gender-neutral pronouns such as they, them, and their until establishing which pronouns the patient prefers. Instead of genderqueer patient, we can say person who identifies as genderqueer. Instead of biologically female, we can say assigned female at birth or designated female at birth. And instead of bisexual, we can say that the person identifies as bisexual. Instead of unvaccinated, we can simply say that the patient has not received an HPV vaccine. These are some references and additional resources which you can use to augment and update your knowledge of inclusive language. This concludes the module on inclusive language in medical education. Thank you for completing this module.